let's go ahead and get started. Welcome everyone. Today we are here for the Congenital Surgery Database, the version 6.22 upgrade webinar. Today we will start with the pre-op lab section and get through diagnoses, and if we have time, we'll continue on. Today is February the 22nd, 2022. So welcome everyone, and let's go ahead and get started. For the agenda today, again, we're just going to jump into this webinar, this upgrade webinar, and again, we're going to start with the pre-op lab section. On the webinar today, Carol is off today, so she left today's webinar up to myself and Chastity and Melinda. So we, Chastity and Melinda will do most of the heavy lifting today, so they will lead us today on the webinar. Also from the STS, we have Addie Dolan and myself, and we also have Leslie from our core group joining us today, and then from the IQVIA team we have Joe and Michelle joining. Again, just as a friendly reminder, please submit your questions via the Q&A function. I won't be able to monitor the Q&A as well as the chat box, but again, please just remember to submit your questions via the Q&A. Also, just a reminder to please keep your questions submit questions just to the sections that we're talking about today. If we have time at the end, we'll answer additional questions. But again, just please keep your questions focused on today's webinar topics. So with that, let's go ahead and hop in and let's get started. So I'm going to turn things over to Chastity. Hold on just a second. Let me switch my screens for you, Chastity.
Perfect.
Here's screen. Sorry, guys. All right, share. All right, you should be able to see my data collection forms, Chastity.
Yes, I can.
Okay, perfect.
We are going to get started with section H2, the preoperative labs and testing. And as you know, for the congenital database, there are many, many new fields here. So just as a background, you know, the legend is at the top of the data collection form, way back on page 1. So you can refer to that. But just as a recap, if it is a white background, if the field is in white, as Vanna is helping show with her cursor, that is a field that is open to everybody. So regardless of the patient age, if you're entering a patient into the congenital database, that those are fields you would fill out for everybody. Those in the purple background are for the 18 and older population only. So Melinda and I are going to tag team this and go back and forth, because as you notice already with lots of purple on the screen, that we have lots of adult only fields coming. And if it's a blue highlight, this means it's a new field for us in the database. It may exist in the adult database though. And so we'll be borrowing some definitions from them. And if it's highlighted in green, that means it moved from a different location in the data collection form. So it's not a new field, just a new location for that field. Okay. So when we look at pre-op labs and testing, you have a parent-child field first that says preoperative labs available, yes or no. And so that's your parent to opening the other child field. So if you answer no, you don't have anything to answer in that section. However, if you answer yes, then you're going to fill out which labs that you have available. If you do not have these lab values available, you would leave the field blank. And looking at the adult definitions, by and large, these lab fields really, they ask for the lab values closest to surgery, but within 30 days of surgery, unless otherwise indicated. So some of them do have a longer, as we get into the adult only fields, you'll see that some of them, like a hemoglobin A1C level, has a much longer time frame than 30 days prior to surgery. And then you see the next section, we have the 18 and older labs. So you would only collect the white blood cells, hemoglobin, A1C, and so on in this section on the patients that you are entering that are your adult congenitals or greater than equal to 18 years of age. And then another field down there, the MELD score. So the MELD score will actually be auto-calculated by your software, but it's going to take values to calculate it. It's going to take the creatinine, bilirubin, sodium, and INR that you've entered above to give you this MELD score. And you can look up and read about the MELD score, which I had to do prior to this webinar. But what it is, it's a model for end-stage liver disease. And so that's why it would use creatinine, bilirubin, INR. and sodium to calculate that. And so again, you won't calculate it, your software will, as long as you have those values available and entered into the database. So then down to pulmonary vascular resistance, there's nothing new related to pulmonary vascular resistance. It's highlighted in green because it has moved from another section in the data collection form to be in this new section of preoperative labs and testing. So nothing new there. And it will be answered on all patients. And of course, it's already stratified by weight if you are, was it greater than or equal to 40 kilos versus less than. And so at this point, I'm going to turn things over to Melinda, who will now go through the rest of the testing that's for 18 and older, and then into the preoperative medications. Melinda?
Thanks, Chastity. So good morning, everybody. Well, at least it's morning my time. So welcome to the webinar. So the first thing I'm going to talk about is the pulmonary function test. And basically, we're looking for whether it was performed or not. And if it was performed, what's your percent predicted for your FEV1, and then your DLCO test. The training manual will be pretty laid out as to which value you take, whether it's pre-bronchodilator or post-bronchodilator. And so it'll be very clear that you'll know which one to code into the form. As far as pre-op meds go, oh, room air ABG. Sorry, I missed that one. So this is a new one for you guys. This is an adult only field. So this is a room air ABG within 30 days. And that's the key. They have to have a room air ABG. If they have an ABG that's not on room air, you just code that as no. And then if they do have one, we want to know what the CO2 level is and what the oxygen level is. And a lot of these values play into the chronic lung disease criteria. So it's nice to have all of these things, especially when you're going through your chronic lung disease criteria and determining if the patient has chronic lung disease. We'll move on to pre-op medications. These again are just for the adult, the 18-year and older. As you can see, most of these medications have a time frame. So for example, ACE or ARB is within 48 hours. Amiodarone is prior to surgery, and it's further delineated, you know, were they on it at home, or did they start at this admission, or do they not have it? If you look in the anti-anginal section, you're going to notice that the first one is beta blocker within 24 hours. Yes, no, or contraindicated. For adults, this is an NQF measure to get the beta blocker within the 24 hours for isolated CABGs. The next several drugs under the anti-anginal, beta blocker, calcium channel blocker, long-acting nitrates, not short-acting, just long-acting, like Mdor, IV nitrates, and other anti-anginals. So when you look at the beta within 2 weeks, calcium within 2 weeks, the long-acting nitrate, and the other anti-anginal, which is basically Renexa. It's not the only one that falls in that category. You're looking to see if these patients were on the therapy for 2 weeks prior to the procedure. The IV nitrate is within 24 hours, and it's like a continuous nitrate drip. It's not just a one-time shot of IV nitrates. We don't count one-time doses for that. And this all, again, is pretty very clearly laid out in the training manual and in adult, and I know that we're going to transfer a large majority of those definitions over to your training manual. And then we move to the antiplatelet medications. So we want to know about ADPs, which of course includes your P2Y12, drugs like Plavix and Brilinta, and things of that nature fall into here. And we want to know, were they taken within 5 days, and the number of days that they were discontinued. So if they took them up to 2 days prior to surgery, then you'd say it was only discontinued 2 days before surgery. Because those do affect bleeding quite a bit, the bleeding risk. Aspirin, we want to know if it's within 5 days. We also want to know when it was discontinued prior to surgery, the number of days, and was this just a one-time aspirin dose? So like sometimes you have patients come in and they just get a one-time dose of aspirin, they go to surgery. So we are looking to differentiate whether this is long-term aspirin or just a one-time aspirin dose. And then we're going to look at our glycoprotein 2B3A drugs. These are drugs like Agristat, drugs that they give in the cath lab to prevent clotting and platelet function. So, and these are drip drugs. So you would find those on your most often in your cath lab. They've been given there, and then the continuous infusion would continue afterwards. And then we move into, and those are within 24 hours. So each one, as you'll notice, each one of these drugs has a time limit. So for your anticoagulants, like your sub-Q ones or your IV ones, so like your heparin, your Lovenox, they want to know, was it given within 48 hours? It's not a one-time dose though, so if you just get one dose, we don't capture one-time doses, but if you're getting Lovenox every 12 hours, then you'd want to capture that within 48 hours of your surgery. Coumadin, they want to know if you've had Coumadin within 5 days and the number of days that it was discontinued. And then we go into like our direct oral anticoagulants. These are drugs like Eliquis is a good example of this. And they want to know, was that given within 5 days? And if it was, how many days was it discontinued prior to surgery? And then the last drug in this anticoagulant section is the thrombolytics, like your TPA. And again, this is within 24 hours, and it does include a one-time dose. If you get a dose of thrombolytic, we definitely want to capture that because it will increase your risk of bleeding. We move next into our inotropic agents. These are drugs like dopamine and butamine, and it does include vasoactive drugs and inotropic drugs in this category in the training manual. It's not just purely inotropic drugs. And were the patients receiving these drugs within 48 hours of the procedure? And then lipid lowering is next. And we're looking at all kinds of lipid lowering here. We're looking at, was the patient on a statin? Was the patient on a non-statin? Was the patient on a statin plus an other? So just, and this is within 24 hours. There's been studies that actually show that this decreases some inflammation to provide that within 24 hours. And then steroids, last drug that we capture for the adults greater than 18 would be within 24 hours. Now, these are systemic steroids. So we don't include like inhalers or creams or nasal spray. This is like, you know, like you're taking a prednisone tablet, or you get a steroid injection, an IV injection. So systemic steroids. And the reason we capture those is because of the risk that it adds to the patient for infection and wound healing if they've had steroids within 24 hours of surgery. So I'm going to let Chastity continue. We're on this tag team.
Thank you, Melinda. That was fantastic. And I know we'll have some questions at the end to talk about some of those medications and such. So let's move into now section I, which is diagnosis. There's not a lot of change here. You notice that we still want you to select all of the diagnoses that apply. And then of course, you're still selecting one primary diagnosis and one fundamental diagnosis. And each of the diagnoses are labeled in the data collection form if they cannot be a primary diagnosis or if they cannot be a fundamental diagnosis. So you know that we have a few things that can't be one or the other, or can't be one and the other. So the data collection form nicely lays those out for you. And again, it's still by kind of major categories of septal defects and down into each individual type of those septal defects, and then on over into the appropriate diagnoses that are categorized in those defect sections. A lot of the new diagnoses that you're seeing, you may be seeing lots of blue background here, which are new terms. Some of these you will see that we have a few new diagnoses, things that, while we were in our calls or getting questions from you where we said, gosh, it would be really nice if we had this diagnosis in the database. And others just provide some more granularity to an existing field. So if you take, for example, the AV canal diagnoses, you see that we still have the existing field of 100 AV canal complete. And now to make it more granular, we have said left dominant, right dominant, or balanced. And so before you could only get to this information if you were a long list user, and you could do that, but STS couldn't get to that information because they still only saw the AV canal complete. So now we have more granular terms. And so if you have, it's not inappropriate to use the code 100, but if you know you have a balanced AV canal, or you have one that's left or right dominant, you could instead select the more granular term. This is true of an intermediate type AV canal as well as an incomplete or partial AV canal. What was moved into the AV canal section then is common AV valve insufficiency. It made sense to have it here, as well as term 830, which is single ventricle unbalanced AV canal. And the thing I'll point out about this term is it is included twice in the data collection form on purpose. We left it in the single ventricle section, as it is a single ventricle unbalanced AV canal, and also moved it here to the AV canal section, just more for ease of use. You only need to use one, and it doesn't matter where you select it. And if you're not collecting the data on paper, it'll likely only be listed once in your software. But just so you know, this is not an error. We purposefully added this diagnosis term twice into the data collection form. All right, so keep scrolling down. And you see it's many of our same diagnoses. When you get down to the tricuspid valve, so right heart lesions, tricuspid or non-systemic AV valve disease, and Epstein's anomaly gets included here. And you'll see we added code 2700. And this is dysplastic tricuspid or non-systemic atrioventricular valve, non-Epstein's. And this is taking the place of 3 tricuspid valve diagnoses that they currently map to a term just like this. But now we're just going to make this happen officially in the data collection form. So we're going to remove the terms 380, 390, and 400, which spell out the different types of tricuspid valve dysplasia that are non-Epstein's related. And we're going to have just one term to cover all of this under code 2700. So dysplastic tricuspid or non-systemic AV valve, non-Epstein's. If you have tricuspid regurg or stenosis or regurg and stenosis, this would be the term that you would use. All right. And then as we keep scrolling, you're going to see that we have some new shunt failure terms. And so we've always had code 2130 shunt failure, but now we have shunt problem, and then further down into a shunt problem with excess pulmonary blood flow or shunt problem inadequate pulmonary blood flow. So it gives a little bit more granular detail about the reason that you are coding shunt failure. And you see some light green text occurring underneath some of the diagnosis fields that Leanne is highlighting. And that's just really saying that this is also a field that is available in the current adult database. And so it's just laying it out here. So keep scrolling down. All right, for HLHS, again, we get into more granular terms regarding the subtype of your HLHS. So now you can formally select if you have both aortic and mitral valve atresia, or if one is stenotic versus atrectic, and pick your subtype of HLHS if you know it. Sometimes we have transfer patients and we don't know what type of HLHS they have now that they're 17 and coming back in for some other type of repair. So you may still have to use code 730 HLHS, but if you can subtype it, then you want to pick one of the more granular diagnoses for those patients. And then you see there's our 830 single ventricle unbalanced AV canal, again, also located under the single ventricle section. Then when we get into transposition of the great arteries, we added some combination terms here. So with both the congenitally corrected TGA as well as TGA in and of itself, we've added with or without VSDs, do you have an existing coarctation or arch hypoplasia at the same time? So they're combo terms that have been added to each of those diagnoses. All right, same with the anomalous aortic origin of a coronary artery. We added more granularity where you can talk about if it's left or right, or if there's an intramural coronary. Under vascular anomalies, again, we added some more terms regarding some compression by a vessel. So whether it's of your esophagus or tracheal compression by a vessel. And as we keep moving on down, we formally added interrupted IVC with azygous continuation. This previously was just housed under a systemic venous anomaly, and now we can get specific and say we have an our systemic venous anomaly is truly an interrupted IVC with azygous continuation. It cannot be primary or fundamental as noted on the DCF. For mediastinitis, we added deep and superficial. And again, this comes from, feedback from the calls and things that we know people were looking for some more granularity around those terms. And then when we get into cardiac tumor, the existing term was always 1350 cardiac tumor. That's going to change to be cardiac tumor unspecified. And then otherwise, we added terms 29, 30, 40, 50, and 60 so you can enter what type of cardiac tumor the patient is diagnosed with. And I'm going to turn it back over to Melinda, where she can talk about the valve-related diagnoses. But before I do that, I do want to mention, we lumped together essentially some valve names based on where they're located. So if you see, you've got aortic, neo-aortic, or truncal valve. So if you think about where the aortic valve is located, all of these, whether you're the neo-aortic valve or you're the truncal valve, you're located in the aortic position functioning as an aortic valve. This is true then of the mitral valve, which can be the systemic AV valve. The tricuspid valve can be the AV valve of the non-systemic ventricle, as well as the pulmonary valve or neopulmonary valve in the pulmonary position functioning as the pulmonary valve. So you'll notice that in the heading. So regardless of whether you have truncal valve insufficiency or aortic valve insufficiency, or it's your neo-aortic valve following, say, an arterial switch, you would fill out these questions for patients that are 18 and older, the separate diagnoses related questions for those patients. So Melinda, go right ahead.
Thanks, Chastity. That was a great overview. So let's talk about valves now. I'm not sure how much of this you had on your old form, but I'll try to break it down fairly clearly. So the aortic valve, and I'm just going to use the terms I'm familiar with. So aortic, neo-aortic, and truncal all go together. The first question wants to know about the valve insufficiency, and whether you have any or you don't have any, and or it's not documented. Then we look at stenosis, and the type of stenosis. Is it mild, moderate, or severe? We also look at the hemodynamic data for that particular aortic valve. So we want to know the valve area in centimeters square, the mean gradient, and the jet velocity or peak velocity. In the training manual, these are fairly, I would say, clearly laid out as to, for example, we have a priority source document for hemodynamic measurements and obtaining them that goes through, you use this source first and you use this second source and you go there. So it's laid out pretty easily to help you identify which valve area you want to stick in that sequence 1095 there. We also have a lot of, I think, pretty good examples of what does a valve area look like on an echo report, different ways that it might be displayed. And we also have a priority source to take the VTI as opposed to another measurement. So I think it's pretty laid out. Since we've done that, I've had a lot less questions from data managers which makes me feel that I'm pretty confident that it's laid out and the instructions are pretty clear. So then it goes down and wants to know if you have aortic, neo-aortic or truncal valve disease. And with this disease, they want you to choose the primary etiology. And you can see there's lots of choices here. I'm assuming bicuspid valve disease would probably be a fairly common one if you were entering an adult patient into here. If you don't know the primary disorder or the etiology, or it's not documented at all, or it's something other that's on this list, then if you scroll down, Leanne, there's a not documented section right there. So that's for etiologies that aren't on this list, etiologies that aren't documented. Then we go into the mitral or the atrioventricular valve of systemic ventricle. That's a new term for me, so I'm just going to say mitral. So mitral, we're looking for mitral insufficiency, much like the aortic insufficiency, and we're looking for mitral stenosis, and then we want to know the degree of the stenosis, whether it's mild, moderate, or severe. And don't worry, you don't have to figure that out. It has to be documented by the physician, the degree of that stenosis. We don't expect data managers to figure out the degree of the stenosis, even though I know there are calculations out there to do that. Again, we have hemodynamic data that we want on this particular valve. We want the valve area and the mean gradient, much like the aortic valve. And then we want to know, does this valve have valve disease? Now, I'm sure this might be foreign to you. It's even sometimes foreign to the adult data managers. It's the Carpentier classification. And as you can see, we have this etiology of the mitral valve laid out very differently from the etiology of the aortic valve. The Carpentier classification is used to describe the mechanism of valve dysfunction, and it's based on the opening and closing motion of the leaflets. So if you have class 1, you have normal leaflet mobility. If you have class 2, you have increased leaflet mobility, such as a patient that might have a flail mitral valve or a prolapsing mitral valve. If you have class 3A, it's restricted in systole and diastole. It might be like rheumatic is typically would cause that. And then we have the class 3B, which is restricted in only systole. And then we have a mixed lesion, type 2 and type 3A. But the way this is laid out, so if you're reading your echo report or the etiology and the surgeon says, this is pure annular dilatation, that's your etiology, that's the problem. You can see that that is a class 1 diagnosis. So pure annular dilatation is under class 1. That's the only place it is on this chart. So you know what your class is, if that's your etiology. But you'll also notice that you've got endocarditis under class 1 and class 2. So in situations like that, you're going to have to clarify with the provider. The provider is going to have to tell you what class the patient has. If you don't know the class, because I'll be honest, a lot of surgeons don't document this. So data managers struggle with this. Then we do have the other unknown, not available box that you can select. This just takes a little getting used to. Sometimes you'll see anesthesia documenting these classes in their documentation on echoes at times. You can find it there. It's, if you're not used to, if the surgeons aren't used to documenting this, it's probably something you'd have to work with them to get them to document. The data manager can determine the class if they feel comfortable, like if there's documentation that says you have a flail mitral valve leaflet. Well, flail is class 2, it's increased leaflet mobility. You can feel pretty confident that that's a class 2, and you could code that yourself. It just takes a little getting used to. It's probably not the easiest thing in the world to do. We also have some other disease processes down here separated out. Acute papillary muscle rupture, re-op of a failed previous valve repair or replacement, and then other unknown or not available if it's none of this. So then we go into the tricuspid valve, or the atrioventricular valve of non-systemic ventricle. And again, we're looking for insufficiency and stenosis. We also want some hemodynamic measurements on this. We want to know if there's an annular measurement, and if so, what it is. What's the annular measurement? And then again, the etiology here looks more like the aortic valve. So you want to pick the primary one. You've got a list of things to choose from. If your etiology is not on this list, pick not documented. If the physician doesn't document the etiology, pick not documented. And the pulmonic or neopulmonic valve is very similar to the tricuspid valve. Again, we want to know about insufficiency, stenosis, and then the mean gradient is the only hemodynamic measurement we're looking for here. And then, of course, the etiology, and it's the same principles. Pick the primary etiology. If it's, and this actually has a choice for other, and the other ones don't. So if your etiology is something other than what is listed here, you actually have a choice to put other. Otherwise, if it's not documented, you code not documented. And I think was that where we were going to try to stop at, Chastity, and take questions?
Yes,
Or do
I
you
was going
want-
to just quickly go through, since we have a few minutes, I think, before we need to stop for questions. If we scroll down, you can see the status post section is here, and it will work as previous status post diagnoses have worked. And you know that this is a status post diagnosis is really a copy of the procedure list. And so you won't see a lot of changes here. The changes you do see are related to new procedures and things that have been added. And we'll talk about procedures when Carol returns, because she is the expert on that section. But if we scroll all the way down,
Yes.
you see that we've added a status post fetal intervention.
Sorry for my angry scrolling. So just close your eyes. For those that don't like quick scrolling.
Almost there.
All right, almost there. There we go.
There we go. Fetal intervention. If your patient has had a fetal intervention, whether done at your facility, they were a fetus and the mom came in and had a fetal intervention at your facility, or it was done at another facility, and now is at your program to have a cardiac repair, you will select the status post fetal intervention. From there, you have other fields to fill out. What is the location of the fetal intervention? So was it done at your hospital or this hospital where now this baby is having surgery, or was this done at a different hospital? So no matter if you did your program did the procedure or not, you are filling out these questions. This hospital or a different hospital. Is the fetal intervention information known? Yes or no? So in other words, there's no other way to link the fetal interventions with the baby unless you fill out this information to the best of your ability. And so what we want to collect is the STS participant ID, where the fetal intervention was done, the patient ID, and the operation ID from those interventions. So it may require a phone call to another program. And so we just want you to do the best to your ability to be able to elicit this information from another program. At most, fill out, was the fetal intervention done at this hospital or at a different hospital? But the only way the database can ever go back and link a fetal intervention to now a baby that is born is going to be if we are able to fill out these 3 fields: the participant ID where the fetal intervention occurred, the patient ID, and the operation ID from that operation. So even if it was done at your facility, your fetal intervention is not linked to this baby that's now having surgery today. So you need to fill this out if it also occurred within the walls of your hospital as well. There's otherwise no other way to link that information. And that's where I think that we can, and I see that Dr. Meyer had his hand up, Leanne, so are we able to unmute him?
Oh, yes. Dr. Meyer, you should be unmuted. You should be good to go.
Okay, great. Could you go back to the pulmonary valve
Yes, sir.
diagnosis?
Yes, sir. Sorry, again, I apologize for the angry scroll. All right.
So, time
Oh,
out.
sorry. There you go.
Yeah, I guess I got confused about no, it's down a little further, yeah. About the congenital no prior tetralogy repair. Where do we code if they did have a prior tetralogy repair, or other than using the status post tetralogy repair code, in a different section?
Melinda,
I'm sorry, am I supposed to answer that?
I don't know. I mean,
That's a good question.
we may have overlooked this going through it, but it strikes me that, the vast majority of the patients who are going to need something done to their pulmonary valve have had a prior tetralogy repair. I would say that's well over 50%, probably closer to 70 or 75%. So it seems to me we ought to fix that. If we have congenital no prior tetralogy repair, I guess I can figure out that one. That's a, valve RPS that got balloon dilated or something, but I don't understand why we don't have a choice here for a prior tetralogy repair.
Okay.
Unless we're going to do it, it can be handled analytically, assuming everybody puts in the status post tetralogy repair part. But I mean, it seems more logical to me to go here, or also to go here.
Dr. Meyer, do you think, and I'm thinking out loud here, that you would put that under a re-op or failure of previous pulmonic or neopulmonic valve repair or replacement? Would, I guess, Melinda, maybe that's a better question for you. Is that where you guys would have included that?
We don't have that choice in adult. We don't have congenital no prior tet repair. So I'm thinking maybe Dr. Meyer's correct. I think maybe there should be a congenital
prior,
because we don't have that choice in our.
I mean, you could just make it another, code and just say congenital status post prior tetralogy repair.
right?
Yeah,
So you'd have 2 congenital reasons for an operation, or, part of the, this section.
yeah, that's something we'll have to take that back to review, Chastity and team. Yep.
That sounds great.
Thank you, Dr. Meyer.
Thank you.
Sorry, I should have caught it before.
No.
Should have caught it before, but we didn't. So
Yeah, that's all right. We do what we can. I appreciate it. Okay. All right, Chastity. We had some questions. We could go ahead and tackle those. Did you want me to read those off, or did you want to?
I can read them off if that works.
Yep.
So is there a good time period for the preoperative labs? For example, 30 days from surgery. So yes, all of the preoperative testing and labs will have timeframes that you would use to collect those labs from. So most of which, looking at the adult definitions, are 30 days, but the exceptions will be noted in their definitions in the training manual, such as something like a hemoglobin A1C and such may have a longer time frame than just 30 days. So you'll find all that information when the definitions come out in the training manual. Great question. Okay, won't these pre-op meds overlap what anesthesia enters for their preoperative meds? So yes, you are correct. There is some overlap. However, in not all programs do the anesthesia database, so there wouldn't be overlap for them. For the programs that do the anesthesia database within the congenital database, the timeframes are a bit different. And so remembering, by and large, outside of aspirin and I think heparin, everything is within 24 hours prior to going to the OR. Whereas if you look at the pre-op meds listed here for the 18 and older patients only, you have things that are within 24 hours and then many things that are greater than or equal to 2 weeks prior to going to the OR or within 5 days. And so again, different time frames around each of these meds. So with the different time frames, then it's not really a one-to-one match with what you would enter on the anesthesia side. And again, these pre-op meds are only for those patients that are greater than or equal to 18 years of age, whereas the anesthesia data is for everybody that's entered into the congenital database. Let's see, I'm not familiar with some of these medication classes. Is it possible to get a list of meds that would fall into each class? Also, the pulmonary function testing parameters are unfamiliar to me. Is there additional education on what these data fields mean? So yes, there will be definitions for the pulmonary function testing included in the training manual. And you're welcome to go look right now at what is listed into the adult training manual for what's there, but we will definitely be bringing over those definitions and providing any clarity that is needed, since this is absolutely a new field for us to collect.
Well, what I'd like to say is we
Yes.
don't maintain a list, but of
Correct.
beta blockers or a list of calcium channel blockers, but it's fairly easy Google search.
Google, our Dr. Google friend.
Yeah,
Well, and to speak
Dr.
to that-
Google, you know, but some of these drugs, like I mentioned, Renexa, I think that's in the training manual. It's like the only other anti-anginal I can think that goes in that category. There are some drugs listed in some of these and others there aren't. I think what most data managers do if they're unfamiliar is make a list, have it available. We used to try to maintain a list, but it just got out of hand. There's so many new drugs coming up.
And that's what I was going to say, Melinda, that the reason that you don't find, even in the anesthesia section, lists of medications included in a class is because new drugs come on the scene all the time, and it would be a full-time job to continually make sure you have every drug listed, and especially maybe even those that are available in other countries and things. And so you really have to take your patient's med list, and if you're unfamiliar with the drugs that they're on, you use Dr. Google and you look it up. You're going to become familiar with, just like in the anesthesia section now, you probably are more familiar with what a beta blocker is. And every time you see a kid that's on a metoprolol or something, you know exactly, what that is. And so over time, you'll have less to look up. Otherwise, if we were to provide a list, then when people don't see those 5 drugs in the list, then they're not looking up the drugs that a patient is on, and perhaps the list hasn't been updated. So it's probably much better data management if you have a patient list and you figure out what classes of drugs they're in. I know my EHR actually lists the drug classifications on the medication record, and so that can be a nice kind of cheat sheet for my program. So next question.
Probably for the PFTs, if you're not used to looking at PFT, maybe I think we might do a webinar on that, because of course different facilities have different layout of how their PFTs look, but sometimes it's helpful to lay your eyes on a PFT so that you know what you're looking for, because you're basically just looking for the percent of the FEV1 percent predicted, and you're looking for your DLCO or your DLCO-VA, whichever is the lowest percent predicted. So perhaps we probably could do a webinar to show a couple examples of those.
That's a great idea, Melinda.
Yes. And I think it's a good time to start figuring out where that information might live in your EHR. So if it's an adult patient that's coming to you for surgery, but might not have had their pulmonary function testing, at your hospital, does that come in transfer records? If it was done at your hospital, does that level of testing get dictated into your consult notes and things, or is it somewhere where you have to go into more of a testing or results section in your EHR to find it? So now might be a good time to start thinking about where you would find that information for those patients, since this is a new field.
Well, and we also accept bedside spirometry too. So it doesn't have to be like a formal PFT. So a lot of respiratory therapy departments do those type of testings.
Oh, great. Good to know. All the things we learn from the adult land. With regards to the pre-op med questions for adults, so the training manual named the most common drugs that we would be looking for in these categories that aren't normally seen in kids. For example, other anti-anginals. I'm not familiar with some of the drugs being mentioned. It might help to ensure that they get caught during chart review. So again, I think we've already answered this and explained this. We're not going to put out lists of drugs in each of the categories, but you need to look up the meds that your patient's on. You can keep an internal list yourself so that when you continually see that your 18 and older crowd is on, a certain type of med, is that a list that you tape up on a whiteboard next to your desk? Absolutely. So you're more than welcome to keep your own list. Next question, pulmonary valve etiology. If the pulmonary valve was not repaired at TOF repair, it would be acquired pathology, as in it didn't need repair. It's rare, but it can be. If the pulmonary valve was repaired, it would be previously repaired. Absolutely, I understand that you're commenting on exactly what Dr. Meyer brought up about how to handle, certain situations with TET repair or without TET repair. So we're gonna take this back and obviously have a discussion about this. So thank you for driving that point. It makes sense. Next question, will the documentation enumerate which specific meds fall into the adult category? For example, what meds are statins? And again, for the adult section, will it be appropriate to have self-reported meds documented into the form, meaning the administered med wasn't given at the hospital, but at home, and the patient reports that it was taken? So yes, absolutely. So when patients come into the hospital, obviously we do some type of med reconciliation and know what meds the patient has been on at home. Every hospital does this differently, but obviously it's being done. So it, even your current anesthesia meds that you're collecting can be based on self-report. So especially these, looking at the adult data collection form where you were on some, calcium channel blocker for at least 2 weeks prior to going to the OR, that doesn't mean you were in the hospital where we were administering a calcium channel blocker to the patient. You could have been at home and been on a prescribed calcium channel blocker. So absolutely, however you elicit the medication information from your patients is appropriate, especially adults that come in and say what meds they're taking. And we're not going to, again, list the meds into specific categories. Go ahead, Melinda.
Just to add a few things. So some of these meds have strict timelines. So for the beta blocker, within 24 hours. So when you're doing a home reconciliation, you have to have a last date and time to determine if that's been given within 24 hours, unless the patient took the beta blocker the morning before surgery, right? He just came in, he just took his beta blocker, and now he's having surgery. And same with ACE and ARB. So some of these are fairly strict on their time. So, and this is all pretty laid out in the training manual very clearly. We even have how to count number of days discontinued in the training manual, so that we're all counting our number of days discontinued the same way. But yes, you can definitely look at what the patient says he's taking at home. Most of these are, as Chastity said, a lot of these are home meds that they've been on, especially the anti-anginals, for 2 weeks.
That's great. Thank you, Melinda.
I can take the next one, Chastity.
Oh, okay. Yes, go right ahead.
So the next one, have the full data specifications been released? If so, where can we obtain them? Looking at the data collection resources page, and just see the 2 forms currently on the screen. That's right. So the data specifications have been released to the vendors and the any of our participant generated software sites. So the full data specs have been released to the vendors. They are reviewing them now. We have a meeting, a vendor call, and I think in a week or two to go over the data specifications with the vendors. We won't release the completed data specs to the participants until we've had that meeting with the vendors. Once they've had a chance to review them, let us know if they find anything that needs to be corrected and then re-released. So once we have our call with our vendors and the specs, we were able to determine there's no major issues or anything that needs to be corrected, then we will release those to get those posted on the STS website. And also, the vendors have to be certified and all of that fun stuff. And I think Katrina had a question regarding the software specifications. Paul is working, those will be released this week. Katrina, if you have any questions, more specific questions about the software specs, if you could just reach out to Paul directly, but I know he is getting those finished up ASAP. And I think this next question is for you guys, Chastity, regarding
All
drugs.
right, regarding pre-op drugs, what about drugs that are multi-use, can be both beta and alpha?
I'm not sure
I'm not
which one
either.
which ones Sarah specifically talking about. Are you talking about inotropic drugs that can be beta and alpha? Are you talking propranolol? Okay, well that's beta blocker.
Yes.
All the laws. That's how I remember.
Hello. Yep, that's me too.
All right.
Okay, are there any other questions? Anything else that we can answer about this section? I know it's a lot to take in. Oh, okay. We are a vendor. We have not received them. I guess we're not on the mailing list.
If you have not received the data specifications, if you could email me directly, I'm going to put my email address in the chat box. If you could email me directly, but yes, the data specifications should have been sent to all the vendors. So again, just email me and I will send you directly over to Paul and to Derek. So I will get that information to you ASAP. The DCF on the website, right? The DCF on the website, that is, again, just note that is a draft data collection form, so it hasn't been finalized. So just there are some minute changes that may happen, but again, the DCF is just the draft version. Once everything is finalized, we'll post a final version. But I downloaded, this is the draft from the website. Are you talking about this one on the right? But I got this one directly from the website, just FYI.
Leon, there's a comment in the chat from
Right.
Noel. Okay. As a vendor, we were not asked for feedback. We were provided some of the specs.
Okay. No, if you could, there is a vendor call scheduled for, I believe, in a couple of weeks. If you can, Noel, just reach out to me directly. I'll get you in touch with Derek. I believe he sent a communication to the vendors when the data specs were released, and I know the software specs are coming. But there is a vendor call scheduled. I believe the first week of March. I don't know the exact date off my head. But if you email me directly, I'll get you in touch with Derek that has all of that information. Okay.
Jennifer, I see what you're saying about what you pulled up. I think that there's a PDF and a Word document, so depending on which one you have, then it may look slightly different. And what I'm seeing different is just the green text, which means it came over from it's an adult field from the adult cardiac database, is all that one is missing. Those will be completely congruent once they're finalized. But if you want that green writing, I believe if you pull up the PDF, you'll see the green writing, whereas I have the Word version open. The words are the same, it just doesn't have that green text, meaning it came from the adult database. But it's in the purple background, which is also another clue in if you happen to be working in the Word version.
All right. Thank you, Chastity, for pointing that out. I appreciate that.
Sure. Oh, I see Charlene Matillo raised her hand.
Charlene, hold on. Let me see. Oh, nope. She lowered it.
Oh, okay. It was fake.
Sorry, I was trying to find you, Charlene. Okay, perfect.
Okay.
And I know we are close. We have about 3 minutes, so I know I don't want to jump into another section. I was just gonna. Oh, here you go, was sleep apnea discussed?
Oh,
So-
as fields to add?
Is that in the risk factors for you?
Is it,
No, it's not in our risk model. I didn't see anything related. Is that a new?
There it is. Yeah, 460. We have it. That's why I was
Under
asking.
adults,
Yep.
okay.
Yep.
Yeah,
I see.
there.
sleep apnea right here?
That was discussed, I mean, we went through all of the preoperative factor fields on the last call.
Oh, you're
Yes.
welcome, Diane. All right. So yeah, I'd seen it somewhere. All right. Okay, that's all that I have. I'm not seeing any additional questions come in. And again, for the vendors, if you have any questions regarding data specifications or our upcoming vendor call, please email me directly and I'll get you in touch with Derek that has all of that information. And my email is in the chat. So just reach out to me directly and I will be happy to get that information to you. So with that, that's all that I have for today. Let me switch screens real quick. Hold on. I just want to go over, just review the timeline. So today we did get, go up through the pre-op labs through diagnoses sections. On our next call, March 1st, our next scheduled call is for March the 1st, and we'll be covering the valve disease greater than 18 and older. And we'll also, I think we'll probably end up getting into we'll go through ECMO section. So we'll get this timeline updated. And we'll get this timeline updated, and Carol will be back next week to lead us for our next call. So thank you everyone for joining. And if you have any additional questions, as always, please feel free to reach out to us directly and we will get all those questions answered for you. So thanks, Chastity, Melinda. You guys did an amazing job today. I appreciate you guys so very much. And thanks everyone for joining, and we will see you all on our next call.
Thank you, Leanne. Thank you, Melinda.
Thank
Thank
you.
you.
Hey, Leanne, you have a minute?
Hold on. Let me, can you call me directly?
Yeah.
Okay, thanks.
I'll just shoot you an email.
Okay, thanks, Melinda.
All right. Bye.
Bye.